Assalamu alaikum wa rahmatullah. I'm Alzahraini, Respiratory Specialist Intern. I'll be the presenter of today's topic, which is about infant respiratory distress syndrome. Our objectives: introduction to RDS, secondary surfactant deficiency, pathophysiology, clinical manifestation, diagnosis and screening, risk factor for RDS, protective factors, differential diagnosis, management, surfactant replacement therapy, and surfactant complication. Introduction to RDS. Respiratory distress syndrome is a syndrome of respiratory difficulties in newborn infants caused by surfactant deficiency. It is the commonest respiratory disorder in preterm infant. It affects preterm infant with gestation age less than 35 weeks or older infants who have delayed lung maturation, which is known as having a secondary surfactant deficiency. The incidence and severity of RDS is inversely proportional to the gestational age and birth weight, and it has a major effect on RDS. RDS incidence based on gestational age and weight. In picture A, it manifests the smaller the gestational age, the higher the RDS incidence, and in picture B, it shows the smaller the birth weight, the higher the RDS incidence. Surfactant deficiency occurs in term infant also as a secondary to acute lung injury. That's caused by alteration in surfactant secretion and synthesis that result from intrapartum asphyxia, which might produce irreversible changes to type 2 pneumocyte, rendering them incapable of producing surfactant. Another acute lung injuries that cause secondary surfactant deficiency are inflammation and damage in the alveolar capillary integrity. As seen in pulmonary infection, meconium aspiration, oxygen toxicity with baro or volley trauma that cause inflammation, granulocyte migration, macrophages activation, causing surfactant protein A, which is responsible for regulating surfactants recycling and secretion by type 2 pneumocyte depletion. Pathophysiology. The prematurity is the main cause of surfactant deficiency, and surfactant insufficiency is the major cause of RDS. The pathophysiology under the RDS is atelectasis that lead to right to left pulmonary shunt and hypoventilation, leading to hypoxemia due to the shunt and CO2 retention due to the hypoventilation. And as a result of high CO2 levels and hypoxemia, anaerobic metabolism and acidosis will occur, provoking pulmonary vasoconstriction. Therefore, pulmonary hypoperfusion will result as a consequence, leading to endothelium and epithelium lining damage, and then plasma leakage. Ultimately, cell necrosis occur, forming hyaline membrane, and this is what causes RDS. Hypoxemia also directly causes decrease in surfactant synthesis. As a result of this process, the alveolar damage will continue in circle. In addition to the surfactant deficiency, the structurally weak chest wall will also decrease the lung compliance and increase the tendency to collapse. The newborn ribs are more horizontally aligned compared to the adults, which make it difficult to generate a greater negative intrathoracic pressure in the presence of poor lung compliance. In picture A, you can see the right to left pulmonary shunt that occurs due to the hypoventilation of the alveoli. In picture B, you can see the difference between newborn and adult chest wall. The newborn chest wall is soft, compliant, providing little opposition to the natural recoil of the lungs. Morphology. On gross examination, the lungs are solid, airless, ruddy, liver-like appearance, as you can see in the below picture. Clinical manifestation. Signs of RDS appear immediately after birth or within 4 hours. Tachypnea usually occur first after tachypnea worsening of intracostal and subcostal retraction, paradoxical breathing, and audible grunting are observed due to the partial closure of the glottis. Nasal flaring also may be seen. Chest auscultation often reveals the inspiratory crackles. Cyanosis may or may not be present. If central cyanosis observed, it's likely that the infant have a severe hypoxemia. Diagnosis: radiographic features. There is diffuse hazy granular opacities with the presence of air bronchograms and hypoaeration. Regarding the blood gas, hypoxemia is the hallmark due to the impaired gas exchange and combined metabolic and respiratory acidosis. The respiratory acidosis is due to the CO2 retention, and metabolic acidosis is due to the lactic acid accumulation that caused by anaerobic metabolism. Radioopic appearance of severe respiratory distress syndrome shows diffuse hazy appearance with low lung volumes, air bronchograms that extended to the periphery, as you can see in the both chest X-ray. The screening for RDS occurs by measuring the lung maturity through a process known as amniocentesis, which is the withdrawal of amniotic fluid from the uterus for testing lecithin sphingomyelin ratio. LS ratio of less than 2 indicates fetal lung immaturity, and a ratio of less than 1.5 indicates a higher percentage of RDS incidence. Risk factors for RDS are prematurity, which indicates immature lung, therefore surfactant insufficient, multiple pregnancy, as in twins and triplets, because they are prone to prematurity, previous infant with RDS, male gender, cesarean section, because there is no stress that occurs through the C-section as in normal birth, since this stress is responsible for extrauterine transition. Maternal diabetes, increased glucose in fetal circulation that will increase insulin secretion, reducing surfactant synthesis. Eventually, intrapartum asphyxia cause changes in type 2 pneumocyte, which I mentioned previously. Protective factors that reduce the incidence of RDS are maternal steroid, which increase the surfactant synthesis, pregnancy-induced or chronic hypertension, prolonged rupture of the membrane, which is the PROM, chorioamnionitis, cause chronic stress for the fetus, which is the same concept as in the birth. Stress causes more surfactant production. Differential diagnosis that we have to make sure that the fetus does not suffer for: TTN, which is the transient tachypnea of newborn, congenital pneumonia, pneumothorax, CHD, PPHN. Management: respiratory, prevent hypoxia and acidosis, prevent worsening of edema and atelectasis, minimize barotrauma and hyperoxia. The supportive management: optimize fluid and nutrition, perfusion, infection, and temperature control. The respiratory management and ventilator assistance: oxygen therapy, nasal CPAP, mechanical ventilation, high frequency ventilation, and ECMO. Surfactant replacement therapy could be in form of prophylactic as prevention, which is a single course of prenatal corticosteroid given to the mother of anticipated preterm delivery before 34 weeks, improves the survival and reduce the RDS incidence. And it could come in form of treatment after birth as early rescue therapy with clinically confirmed RDS. Surfactant is given within 2 hours of life. And as you can see in the below picture, the surfactant differs based on the type of the surfactant that given and the newborn weight. All surfactants are delivered by ETT. Studies suggest that surfactants better administered with infant in a supine position. The main treatment is continuous positive airway pressure, CPAP, and is the traditional support mode used to manage RDS because of the hazards of the endotracheal tube, ETT. So we only intubate to administer surfactant, but if the infant condition deteriorates rapidly and the oxygenation does not improve, plus there is apnea or acidosis, a more aggressive approach is required, which is endotracheal intubation as an elective procedure. With premature newborn, we try to oxygenate with the lowest possible FiO2 to avoid complication of high oxygen. So our target saturation is 88 to 92. Surfactant complication is tube obstruction, hypoxia, bradycardia, over distension. Mostly these complications are due to the administration of the surfactant. So if there is tube obstruction, that leads to bradycardia and hypoxia. And the after giving of surfactant complication is pneumothorax and over distension. During the surfactant administration, it could cause the obstruction. This is why we said we should give the surfactant over multiple doses to avoid this obstruction. And that's it for today's topic.